Thank you, Dr. Madhu. I am from Indore, and I'll be speaking about retina and uvea related causes for sudden vision loss. I think this is what we usually come across. Don't have any financial interests. At the outset of my presentation, I would like to mention that preferred examination method for examination of the retina is slit lamp biomicroscopy and indirect ophthalmoscopy. And yes, if you are not having skill for indirect ophthalmoscopy, at least direct ophthalmoscopy, but just like what we do in kind of screening camps, better not to diagnose based on presence or absence of red glow. So the vitreoretinal causes being vitreous hemorrhage, retinal detachment, vein occlusions, BRVO, CRVO, arterial occlusions, BRAVO, CRAVO, age-related macular degeneration, wet type, central serous chorioretinopathy, photic retinitis, and the uveal causes acute anterior uveitis, VKH syndrome, acute retinal necrosis, fovea-threatening retinitis or choroiditis, like toxoplasmosis and serpiginous choroiditis. This is not an exclusive list of causes, but yes, these are kind of which we usually come across in our practice here in India. So retinal detachment, we have, like all of us know, regmentogenous retinal detachment, where there is a retinal break, tractional retinal detachment, and exudative retinal detachment. I am restricting because exudative will be covered in uveitic causes, and tractional is more or less related to diabetic retinopathy. This is mainly for regmentogenous retinal detachment. Preceding flashes and floaters is a very typical complaint associated with sudden vision loss of RRD. Curtain-like shadow covering the visual field before total loss of vision. It's a typical description, either from one side or from below or from up, depending on where from the retina is detached. And yes, myopia, pathological myopia is a higher risk factor. So if there is a pre-existing pathological myopia with this kind of symptoms of flashes and floaters and sudden vision loss, and with an IOP of less than 10, then usually we diagnose it without even examining the retina. You can diagnose it as having a retinal detachment. So a complicated cataract surgery, if there is a history, or if you are seeing in slit lamp that the surgery was complicated, then also you can consider possibility of retinal detachment. So in the history itself, and any trauma of just usually doesn't happen immediately after trauma, anything more than 1 or 2 months. Usually we see after 6 months a retinal detachment. So this is the typical picture. Like if you are seeing anything like this, even with direct ophthalmoscopy or indirect ophthalmoscopy, better to have indirect ophthalmoscopy. This is a typical picture that the patient is having a retinal detachment, especially these folds, retinal folds. They mention that they suggest that it is more likely a regmentogenous retinal detachment. So visual acuity is usually PL present, maybe even 6/6 if macula is attached. And if PL is absent, then better consider optic nerve pathology, because most of the time, almost always, it is PL present. And we don't see any afferent pupillary defect in retinal detachment. And IOP is usually low, and if it is less than 5 millimeters of mercury, then consider a serous choroidal detachment also. And what to do at a comprehensive ophthalmologist level? Better to hurry to refer, because this needs surgery as early as possible for best results. We can operate even up to 3 months or even up to 6 months or even after 1 year. But if you are expecting a best possible result, then I would suggest better to refer for surgery as early as possible. And if macula is attached, all the more need. If it is a sudden onset of flashes and floaters and macula is attached and you are seeing a quadrantic retinal detachment, then there is all the more need for a hurry. And if getting delayed, start topical steroid and cycloplegic till the time of surgery. This actually prevents that choroidal detachment and ultimate prognosis. So whenever you are referring a patient, better to start on topical steroid drops at least 6 times a day and a cycloplegic, so that the patient gets benefited when the patient goes for surgery. So the treatment options that are available, I'm not going into the details. Scleral buckling, vitreoretinal surgery, pars plana with intraocular tamponade, pneumoretinopexy, and if it is very less, like 2 to 3 disc diameters of detachment, then we usually go for only barrage laser for subclinical RD. So it can improve to even 6/6 if surgery is done within 24 to 48 hours after vision loss. So hurry. And if we do it after 1 month, it's a poor prognosis for vision. Usually we get, even if the surgery is very much successful, we don't get anything better than 660 or 636. And after 3 months, then usually the prognosis for surgery itself is like bad. And coming to the other cause, that is vitreous hemorrhage, this is also one of the common causes. Floaters, usually they describe that floaters being red in color, and some of them may describe blood trickling And systemic illness usually is associated, especially older patients, diabetes mellitus and hypertension, and young patients it is retinal vasculitis. And there may be, because any already neovascularization is there, and if there is history of valsalva maneuver, then that is all the more reason for a vitreous hemorrhage. Here retina is visible, but most of the times we may not be able to see the retina depending on the severity of the hemorrhage. So visual acuity is variable even in a single patient, like depending on the hemorrhage, visual acuity may be 662 PL present only. But even in a single patient, if the hemorrhage is on and off visual axis, then the visual acuity also, like optometrist checked, it is 660 and you are checking it is 69. It can happen. And RAPD, if it is there, it is a poor prognostic sign. And in any case of vitreous hemorrhage, if you are seeing any neovascularization of the iris, it is a poor prognosis sign. And IOP is usually normal if it is not associated with neovascular glaucoma. And look for retinal detachment either by indirect ophthalmoscopy if the retina is visible, and or even tractional retinal detachment also in diabetic retinopathy patients. And B-scan ultrasonography if the retina is not visible, and B-scan ultrasonography preferably by a trained ophthalmologist rather than a radiologist, because they don't have much of an idea about intraocular pathologies. So better to get it done by a trained ophthalmologist who can do a B-scan ultrasonography. Then look for change in color. If it is grayish or yellowish, it is more likely a old vitreous hemorrhage, and it is old enough to consider VR surgery if the patient is presenting to you for the first time. Anti-VEGF, be cautious, let a VR surgeon decide. Just because there is vitreous hemorrhage, we cannot inject either Avastin or Lucentis. So what the surgeon will do, either wait and watch, if it is a known etiology like diabetic retinopathy, and if there is attached retina, and better to consider immediate VR surgery if there is retinal detachment on ultrasonography, or there is uncertain etiology. If you don't know the reason, then better to operate, because there may be a retinal break and the patient may result in retinal detachment later on. So the prognosis will be good most of the times, but if the retina is not visible, even if retina is attached on ultrasonography, be cautious when you are explaining the prognosis to the patient, because there may be outbreak atrophy, there may be macular ischemia, TRD involving the macula, CNVM, scar at the macula. So these things we can't estimate before doing surgery in a total vitreous hemorrhage. So be cautious before giving any good prognosis. And retinal vein occlusions, BRVO and CRVO, usually they are associated with hypertension and diabetes mellitus or a thromboembolic disorder. So this is a case of branched retinal vein occlusion. How do you diagnose? These are the flame-shaped hemorrhages and macular edema. Only in it's actually hemi-CRVO, I can say, because you can see it even on the other side. But inferiorly, if you see, there are no hemorrhages. So this is a hemi-CRVO, and this is a central retinal vein occlusion. So these blot hemorrhages and flame-shaped hemorrhages, they are there in all four quadrants, and there is a severe macular edema. So this is how you diagnose. Better to have this picture remembered, and examination with indirect ophthalmoscopy only gives this kind of a picture, because direct ophthalmoscopy doesn't give that overview picture. So field defect type vision loss, BRVO. If there is RAPD, then it is ischemic CRVO. And if there is neovascularization of iris and raised IOP, then already it is long time this thing, and it carries a poor prognosis. And check for systemic illness at your level, and then refer to a VR surgeon who can tackle, or a medical retina specialist. Anti-VEGF is usually given for macular edema. It's not a one-time. Explain to the patient that it's not a one-time treatment and not a cure. And usually injected whenever patient presents. Nothing like we don't inject in 1 week, we inject only after 1 month. It's like whenever we are seeing a macular edema, we usually inject even within 1 week also. And caution about increase in IOP if the patient is being advised intraocular steroid. And laser, usually we delayed. Better not to tell the patient that laser will be done, because immediately we don't do laser. We do laser only when the hemorrhage is clear and or neovascularization develops. Prognosis, treated BRVOs is a good prognosis. Untreated BRVOs, it may result in neovascularization and may result in sudden severe vision loss, moderate vision loss over long term. And CRVOs, non-ischemic, good prognosis, need regular follow-up till 2 to 3 years. So in ischemic CRVO, though the visual prognosis is poor, the purpose of treatment is to prevent painful blind eye is most important. That is to be stressed to the patient. And retinal artery occlusions, systemic illness, the thromboembolic disorder comes first here, and chronic smoking. And yes, spine surgeries causing prolonged ocular compression may result in this. So this is a case of BRAO. This is a case of CRAO with the typical cherry red spot. White retina with a central cherry red spot, sudden onset vision loss. It's a direct diagnosis of a CRAO. This is how a fluorescein angiography looks like. Artery is not filling. And a cilioretinal artery, you may see a sparing of a cilioretinal artery, or you may see a blocking of a cilioretinal artery. So immediately, you need not dilate a CRAO, because usually people, there is RAPD. So you can directly look for a cherry red spot and an embolus. Do check IOP and do eye massage. And you can go for IOP lowering medication, or you can do a paracentesis. This is how we do a eye massage when we see a CRAO. It's not like rubbing the eye. It's like compress, leave it, and for 10 to 15 seconds compress it and then suddenly leave it. So it causes dilatation and it may dislodge the embolus. So the prognosis is almost always nil in a case of CRAO. There is no proven treatment, and those who get improvement or have some useful vision at presentation, it is either because it has recovered spontaneously within 6 hours or the embolus got dislodged. So typical positive scotoma is seen in cases of wet ARMD, not something is missing. It's something like a black spot is seen, and it is only central vision loss in wet ARMD, and moderate vision loss will be there, not a complete severe vision loss. And younger age, if you are seeing, then it is trauma, myopia, choroiditis or chronic CSR. So what we do usually is OCT and FFA and ICG in selected cases, and anti-VEGF is the standard therapy these days, that is Avastin or Lucentis. Prognosis, that is more important. Complete blindness is a rarity, but chances of recovering central vision for fine work also less. So this is how the CNVMs respond. You can see the submacular hemorrhage clearing after VEGF therapies. I think I have to hurry because central serous retinopathy, this is what one can think about managing at their level without referral to a VR surgeon. So what we usually see is a central scotoma or a metamorphopsia, and well demarcated oval shaped area of that is a bullous detachment of the retina involving the or not involving the fovea. You can see this if you can appreciate the bullous detachment. So we need not do investigations if it is a typical case, but yes, we can do a fundus fluorescein angiography and high resolution OCT. OCT is especially for follow-up of the patients. You can either see an ink blot leak or a smokestack leak on fundus fluorescein angiography. And OCT, especially if you are expecting the SRF to reduce, then you can usually look at the SRF resolving. So well-established treatment is observe, counseling for stress and stress relieving maneuvers, avoid steroids in any form, and green laser photocoagulation. All other treatments are just trying, nothing like proved. And anti-VEGF, I prefer not to give anti-VEGF for CSCR. And photic retinitis, we don't have any described treatment, but yes, when the patient comes with, there is a foveal burn, and after follow-up that results in a outer lamellar macular hole. We don't have a proven treatment. Explain to the patient that there will be moderate vision loss for the rest of life. And coming to the uveal causes of sudden vision loss, acute anterior uveitis, you can differentiate from other causes of red eye only by a slit lamp examination. You cannot diagnose or you cannot rule out this without doing a slit lamp examination. So one should understand this. When you are seeing acute painful red eye, you have to do a slit lamp examination. You may see capes and posterior synechiae, and if there is hypopyon, be cautious, it can be endophthalmitis, especially if it is an operated case. And frequent topical steroid and refer for further evaluation. You can start on frequent topical steroids. You need not refer if there is no other complication. But if it is recurrent and if there is associated systemic illness, or if you see any posterior uveitis also, then better to refer. VKH syndrome is other common cause for bilateral sudden vision loss. Acute or subacute decrease or total loss of vision, usually bilateral. Eye pain with redness. Most important differentiation from sympathetic ophthalmia is that there is no history of eye trauma. Otherwise, both the diseases are the same. So, what you see, visual impairment ranges from mild to PL present only, may differ between the eyes, and IOP is usually low. And what you see is usually serous subfoveal or submacular detachments. So, if you look at the angiography, you see early hypofluorescent spots and starry sky appearance in the late phases, the pinpoint leaks and also the fluid filled spaces. So this is a typical picture. You can just remember this if you are seeing any fundus fluorescein angiography picture, and if you see this, just it's a direct diagnosis that this is a VKH syndrome. So usually we prefer to give intravenous methylprednisolone if there is severe vision loss, and followed by oral prednisolone. better to continue the steroids for at least 3 months to avoid recurrence. And prognosis wise, if you are timely treating it and full treatment if you are giving, usually it restores full vision. Close watch is needed for several years as recurrence is common, and chronicity results in complications like cataract, glaucoma. So fovea threatening posterior uveitis, urgent treatment is needed. If fovea is not involved, act fast within hours to days. If you are seeing anything threatening the fovea, immediate action is required. Accurate diagnosis is usually clinically possible. You can just look at the pictures and then remember it. And if there is a suspected infection or if there is a toxoplasmosis like thing, better to start treating the infection and then only start steroids. Don't start steroids immediately. So this is a serpiginous choroiditis. You can see the yellowish edge that is threatening the fovea. I have started this patient on immediate steroids, and that resulted in resolution. You can see this was on 16th of October and this was on 25th of October. Within 10 days, and patient regained 618 vision. So this is a case of toxoplasma retinochoroiditis. Unfortunately, fovea was already involved. Though it healed very well, the patient could not gain much vision. So this is a typical picture of a toxoplasma retinochoroiditis. So better to start on clindamycin and then start steroids after 1 week rather than directly starting steroids. And this is a case of viral-like retinitis which was treated with steroids and antivirals. But right eye gained good vision because fovea was not involved. Left eye could not gain because fovea was involved. This is one more case of acute retinal necrosis. Peripheral exudative retinitis you see, and central vitritis here blocking the view of the posterior segment, and treated by barrage laser and antivirals and steroids that results in good vision. So these are all the common or what we usually encounter as retina surgeons causes for sudden vision loss. Thank you.